Welcome to the PT on Ice Daily Show. I'm Trissa Hutchinson, Doctor of Occupational Therapy, here to talk to you about appetite, aging, and activity today. Now, I have lots of individuals who will come to me and tell me things like they have low energy, they're feeling weak, they just can't get up and go as much as they could before. So I ask a couple deeper dived questions about their overall nutritional intake. I might be asking them, what are you eating throughout the day? Can you tell me what a typical day looks like for you? I might even ask them to track what types of foods they're eating on a daily basis. Typically, this leads me to discover that an older adult may be eating very, very little. Maybe they're eating one meal a day, or they're eating half a meal a day. Or I had a person recently who told me that half an apple and a bowl of popcorn was their lunch, and they had the other half of the apple for their supper. Now, this is a serious problem that we all know in terms of occupational and physical therapy, how this can really impact someone's overall energy because they're not having any gas in the tank to fuel their body throughout the day. This term or this issue was actually coined and phrased as the anorexia of aging by John Marley in 1988. I myself had not thought about it as such. Typically, when we hear a term such as anorexia, I feel many folks are thinking more like late teens to early adulthood, more so struggling with an issue like anorexia, as compared to when you think about an older adult who is eating very, very minimal throughout the day. Sometimes that can just be, brushed off to the side as, well, they're not moving enough, or, they're just not eating, or they just don't have the appetite. And so we don't dive deeper into how we can actually help these people. So that's what we're going to do today. How can we actually address this issue, and how can we, as physical and occupational therapists, move the needle to help our patients improve their nutritional intake? We are excellent at telling our patients how much protein they need to eat, that they should be drinking their water, they should have a well-balanced diet. But are we taking it one step further to see how we can actually make a change in their life? What we're going to do today is ask two main questions and dive deep into each of them to figure out how we can be that hope dealer for those patients. The first question is, what are the limiting factors and barriers to my patient's food intake? What are the limiting factors and barriers to my patient's food intake? We're going to dive in and talk about intrinsic and extrinsic factors that play a role. Then we're going to take it one step further and say, how can I increase access to my patient's food intake? So first, what are the barriers? And then we're going to go into how can I actually increase access to food for my patient? So the first, what are the intrinsic and extrinsic factors that may be associating to limiting intake or limiting fueling my body, impairing appetite for an older adult? Well, we can dive into a couple of different things. When we're talking intrinsic, maybe our patients are experiencing challenges with mood disorders. Maybe they've recently lost a loved one, which has spiraled them into a deeper dive or a depression. And so they are socially isolating. They have a lower drive or desire for food because they're experiencing an actual psychosocial disorder with depression. As a result, can we be, a hope dealer and figure out how we can get them resources to help with that depression? Maybe our patients are experiencing things like changes in their olfactory system. So they don't actually smell the foods that they're eating. I feel like when we talk about food, when we talk about mealtime, that's an experience, not necessarily just something that is always just driving our performance and things like that. And so if your patient is no longer experiencing the smells of the food that's being made, their desire may be decreased. The same goes with their gustatory system. If they have decreased in their taste buds and they're not able to actually taste the delicious food that someone is making them or they are making for themselves, same thing, appetite may decrease. They may have a lower desire to actually eat food. They might be having challenges with weakness. such as frailty or sarcopenia as a result of low physical activity, what we'll talk about in our extrinsic risk factors. As a result, they just don't have the get up and go to actually go make food or make the meal. So there are lots of other factors that play a role here. Maybe they're struggling with their oral health. And so they're either having dentures or they have teeth that aren't as strong, so they can't eat as well. Lots of intrinsic risk factors that can limit participation in mealtime or in eating foods. We can talk about extrinsic risk factors as well. So, does your patient no longer drive? Or do they have a limited access to transportation? That could limit them from social opportunities where maybe they were going out to eat with friends, or they were attending club meetings on a routine basis, or going to church meals where it was a potluck style, or they were going out to a restaurant and they were having meals on a routine basis. And now they're not able to do so due to a lack of transportation. The same goes, maybe they're not able to actually get themselves to the grocery store to buy ingredients for meals anymore. So they don't have an actual physical access to food at the store or at a restaurant. Maybe they have issues, as I mentioned, with their oral health, but they don't have the strength to brush their teeth, or they don't have access to something like a glue for their dentures. And so as a result, their dentures are moving up and down in their mouth. And so they're not eating as much because that drives them crazy. I had a patient who literally stopped eating because his dentures weren't glued down. And so when he was eating every bite, his teeth were nearly falling out. Just getting some glue and getting those cemented down made all of the difference for that patient. So it could be as simple as that. Maybe they're experiencing polypharmacy and they have too many medications on board. And so as a result, that is impairing their appetite. Can we do a screen or something, talking to their provider, talking to the pharmacist about what medications might be impacting their overall desire for appetite and participation in mealtime? Maybe they have a lack of education or understanding of what actual food guidelines are. So I mentioned earlier, we're kind of the pros in this area when we talk about this is how much protein you should be eating. You need to drink your water. You should have a well-balanced diet, all of those things that can move the needle and just increase overall understanding. On the same side, we can also talk about education in terms of understanding what actual nutritional guidelines may mean. I had one patient who had her lab results back that came back that she had high creatinine levels. And so she Googled and had typed in what are high creatinine levels caused by. And what it said was dehydration, intensity of exercise, and protein intake. So my patient told me that as a result, she wanted to do no exercise and was going to stop eating protein. Now, we had already done a screen and she was eating less than 10 grams of protein on a daily basis. Yes, less than 10 grams. She was having one egg per day with 6 grams of protein in it. So we did some education on that actually the high creatinine levels likely were caused by the fact that she was only drinking 10 to 12 ounces of water a day and eating very, very minimal as well. And so when we did some education and explained those things to her, that's how we moved the needle there. So when we answer that question, what are the limiting factors or barriers to our patient's food intake? Lots of different avenues that we can go down. I just want you to make sure you're taking a deeper dive and not just giving them information, but you're asking like, what are the things that are actually stopping them from participating in intaking food? Then let's dive into the second question. So I know the factors, I know the limiting barriers, but how can I increase access to food for my patient? How can I increase overall access to food intake? So, the number one thing that always pops up when I was diving into all the research for this was actually so promising, and it was increasing physical activity. Increasing physical activity. Now, the Journal of Food and Hospitality Research has a great graphic and talks very in detail about how these multiple components of multifactorial systems can support But physical activity was one of the overarching themes. Now, I want you to think about increasing physical activity as a snowball effect to positively change your patient's overall intake of food. Improving physical activity is likely going to increase their strength and increase their endurance. If you increase strength and increase endurance, you are directly improving functional independence. If you are improving functional independence, then you are able to increase someone's access to things like walking to the kitchen. You are able to increase their ability and their tolerance to standing and preparing a meal. You are able to increase their access to walk around the grocery store, to tolerate sitting up and have more energy when they are at a meal or participating in social activities with their friends. Maybe you're able to get them so their family feels more confident taking them out in the community for social events that involve food. Maybe you're able to increase their physical abilities so that they can brush their teeth more frequently. And so they have less pain in their mouth and their overall oral health improves, thus, for increasing their participation in eating and food intake. Maybe they have just overall increased capacity to walk from their apartment in the assisted living facility down to a meal where they're more likely to eat because they are watching other people eat and they're enjoying the company of other individuals. So, physical activity is not just improving strength and endurance, it is also improving overall access to meals. There is also evidence to support that improving physical activity causes an increased appetite because you are burning more calories. And so naturally, your body is going to want more calories. However, when I was diving into this, most of the physical activity overarching themes were more so in related to an individual's capacity and strength to actually get to food and be able to prepare food for themselves. Next, how can I increase access to food? We talked a little bit about education. So, ensuring that the patient understands what is the recommended guidelines for food, how does food work? For many of our older adults, food was something that, if they have a desire for food, then they eat. They don't necessarily have as much education in terms of we need fuel, we need food to actually participate throughout the day to improve our energy. So, knowledge is power, and explaining to them that food is like fuel for your car. If you put fuel in your car, it's going to go farther. If you put food in your body, it's likely going to go farther also. We can do training on things like meal preparation. Maybe they're struggling because they lost their spouse and now they don't know how to cook for one person, and it's daunting when they have all of these leftover meals or leftovers after a meal, and they don't like eating the same thing multiple times. So, can we provide education on simple meals with less ingredients that they can make on a regular basis? Can we get them set up with a chat or a group or a social club where they share recipes back and forth? Or maybe they can get out and participate in, weekly club meetings or something where food is a part of that. I have a lot of individuals who go to, like Kiwanis clubs or church groups where they're eating at those events. We can talk about how oftentimes for our older adults, having smaller packaged food can be less daunting for them. So rather than opening a bag of or a box of crackers where it's an entire box and they feel like they might not be able to eat that whole thing before it goes bad, if you get them smaller packaging of crackers where it's a serving size, they're more likely to open the package and eat the whole thing because they know that they'll be able to finish that before it goes bad, and thus they end up actually eating more quantity than the box would be um, in the time that the box would be expired, because it's just less overwhelming looking at the portion of the snack that they're having. And then lastly, can you be a resource dealer? So increasing patients' access to food. If maybe they don't have the physical capacity, they have no desire, they hate cooking, they've never cooked, they don't want to cook. Can you get them set up with pre-made meals? So I know after someone gets out of the hospital, some Medicare Advantage plans actually will cover something called mom's meals, where they get 2 full weeks of freezer meals. That's, I believe, 3 meals a day for 2 full weeks. There's also things like Meals on Wheels. There are tons of services now where people can have freezer meals or meals delivered. Just be the resource dealer and know what is in your area to help your patients. Diving into all of these different things, increasing access can be huge. So please, please, I want you to make sure that when you're talking about appetite with your older adults, it's not just barking at them what they should be doing. It's taking a step further, diving in, maybe collaborating with your peers, asking the question, what is the actual limiting factor and barrier to stopping my patients with their food intake? And then how can I increase their overall food intake or access to food intake to really move the needle and change their life? Thanks so much for listening. Hope you have a great day.